and welcome to episode 3 of Care to Explain. And I am joined with the amazing Anna Knight. And Anna, how are you? How's your day?
Well, firstly, cheers.
Oh,
Cheers to that. How am
cheers.
I? I'm a bit worried. It's been a tough week in terms of work and winter pressures and worrying about the care sector, to be honest. So I'm okay, but I am concerned about where we are. There's a strike due tomorrow within the NHS. There's all sorts of political things going on, and actually, I feel like we've really been forgotten about in the care sector. So I'm not as chuffed as I'd normally be. How about that? Okay. So, how are you feeling, Obi? Tell me about your week, your day. What's going on for you?
This week so far it's been good. Came down with a cold yesterday, and just when you were speaking about how difficult it is and the pressures the hospitals are going through, I refused to go to the hospital today because I didn't want to be stuck in A&E and I didn't want to have the service. I just didn't want to be told, do you know what, go home, nothing's wrong with you. So, yeah, I really understand when you said winter's coming, NHS is under pressure. What are we going to do about it? So
But
I guess,
the thing is, the NHS are under pressure, but the impact on the care sector is monumental. So everybody is under pressure, and I think you're an intelligent, capable woman most of the time, and the reality is that if you had a learning disability or dementia or a sensory impairment, how do you cope in that environment, particularly if you need help? So the reality for me is that there just isn't enough thought about the people we support, the care sector, the impact that that has on the NHS when we can't help, and actually the general public don't know what we do, and this is my standard statement. It drives Obi crazy when I say we're the fourth emergency service, but you know what? I just feel like we are
yeah,
because we come sweeping in and save the day, but nobody knows that.
right now, if you're, well, on LinkedIn, let me use LinkedIn as an example. Lots of my
Yeah.
friends say to me, "Oh, but what's going on in care?" I'm always seeing posts from people in care complaining about the pressures, especially now. So for
Mhm.
someone who isn't in the care sector, help them understand what we face in care. So when the NHS is under pressure, how does that translate to care?
Okay, so let's imagine there are 14 people who have come from potentially a care home, not one, but say six different, seven different, eight different care homes, and they're taking up 14 beds on two wards. Those beds are really needed by the NHS, and they're really needed because there's a constant flow of people coming in through the emergency department, ED. But if those people aren't well enough to go back to the care home because they've got clinical needs or medical needs, or they're going to be in pain, or they're not able to walk. So, for example, instead of having one-to-one care, they need two-to-one care. The care homes, the domiciliary companies, the supported living, they can't have them come back to their home because they can't give them the care they need to keep them safe. So what happens is the system gets clogged. So what we have to do is we have to get people medically fit and really well before they can return home. So on a regular basis, people are pushed out of bed by the NHS because they need the bed that they're in, unwell and not well enough to go back to their own home, to a care home, to supported living, anywhere, and they get what's called a failed discharge. So they go in to their own home and they boomerang back. And there we go, another block bed. So we have to develop a system where we get people medically fit and well enough to go home. And that's not just old people, that's everybody. We're in such a rush to get people out. We've got these KPIs to hit, key performance indicators. You've got to get people in, get them out within 20 minutes, whatever. But
Yeah,
we've forgotten about the person at the core and that patient and how they feel, and we push them out. Or we can't push them out because nobody's got anywhere for them to be. So they stay in hospital, they decline, they deteriorate, they die. And that's
yeah.
really harsh, but that is a fact.
Okay, so you said it's a cycle. So you leave the care home, go into the hospital, and people aren't fit enough, and they go back into care, and then it becomes a vicious cycle. One of the reasons why when you asked me about today's episode and you were like, what should we talk about today? And I was like, winter pressures. The reason why that came to me was because of that, with the letter you sent to me, the link you sent to me about the winter letter 2025. You've explained to the public how it affects care, but how could providers actually prepare? So everyone talks about winter pressures, everyone talks about discharges, everyone talks about beds being full, but how can providers actually prepare for it?
I think there's a lot of things that we need. We need to have flu jabs sooner. We need to have better planning. We need to start talking about winter pressures in June. Not, oh, it's November, let's have a chat about it.
Okay.
So if we start to prepare and we
Yeah.
have the resources and facilities to keep, and it's not just care homes, it's elderly people or people with learning disabilities or anything that makes them vulnerable wherever they live. We need to prepare to how we're going to support them to remain well through the winter. So, have we got the right medications in place? Are we ensuring that, there aren't slips, trips and falls that are going to happen that will mean that they'll end up in A&E? Are we, as families, making sure that their slippers aren't worn out? It sounds really silly, but a pair of worn out slippers makes people fall. Are people hydrated? And something as basic as the heating comes on, people start to become dehydrated. So are we giving them enough fluid? When you're dehydrated, you get a urine infection, you start to become delirious, you fall over. If you get a chest infection, you become delirious, you fall over. So are we doing the right thing? Should we be spending a bit more money on giving people an antibiotic that's just a very tiny amount that keeps UTIs at bay? Should we be able to immediately give somebody antibiotics when we think there's a chest infection coming? Trust the staff who are caring for that person. They can hear that change. They can hear somebody's cough has changed, their wheeze has changed. Trust the families who are unpaid carers. But if we don't prep and get ready, for example, where are care providers supposed to get COVID testing kits right now? And here's another classic example. I'm what we call, so for people who don't know about care, a purposeful wanderer. And basically
A
what that term
purposeful
means,
wanderer.
purposeful wanderer. So what that basically means is I may have dementia and I just wander up and down because that's what I do in my home, in my supported living room, my care home, because I can't settle. So if I have got
Never heard of
COVID
that term.
and I am wandering around, I'm going to infect the staff, I'm going to infect the other people that live there, and they're going to become ill as well. So if I can't test to find out if this person's got COVID, I can't keep them better supported or help them to wear a mask. If somebody's in hospital and they have got COVID while they were in there or gone in with it, don't send them back to a care home or somewhere everyone can be infected if they are a purposeful wanderer, because the staff can't keep them in their room. That's not right. It's their home. Can't shut somebody in. So everyone has to have some understanding about the difficulties that everybody faces. So we have to understand more about the pressures the wards are under as the care sector, but the wards have to understand that if you send Brian home, who's a purposeful wanderer, on day 2 of COVID, everyone's going to get it.
How about trusted assessors? That's a word that lots of times, when it comes in winter especially, you hear about trusted assessors, and you just sometimes I feel like providers are providers even using trusted assessors? Does every provider use a trusted assessor? Should they use a trusted assessor? At what points should you start thinking about? You said when it comes to preparing for winter pressures, you don't start in November. You could start as early as June. So yeah, why do we start?
Okay.
Why are we just hearing about trusted? I
Well,
know.
first, I probably should say what a trusted assessor is. So,
Yeah,
a trusted
please.
assessor should be, and isn't always, but should be an independent person working on behalf of the care providers. They should be somebody who's highly skilled in care, so an ex-registered manager, possibly a nurse who's run a nursing home, but somebody who completely and utterly understands the care sector. Their role is to manage safe discharges from hospital back into the care sector. So let me give an example. I've got a team of 7 trusted assessors that I manage and support. They're independent, but they're actually funded by 2 local authorities because they get it. They understand how important that is. So a phone call will come from a care home or any type of provider, and they will say, Betty had an accident last night. She was taken in by ambulance and she is on ward 7. Can you go and do a welfare check? Can you see how she is? And can you let us know exactly what's changed for her? This is her baseline. So they'll explain what Betty is normally like. So she walks with a Zimmer frame maybe. She can feed herself.
Yeah.
She's very capable. They will go up to the ward and they work alongside the ward staff. That's a proper trusted assessor team working collaboratively with the NHS. And they will see what happened, why Betty was admitted, and then they will talk to a therapy team. So they'll say, okay, so she's got a broken hip. So she was operated on last night in an emergency. The care home will take her back, but what needs to happen is she needs to have some really good therapy input. She needs to be back to her baseline. And before we get her home, we need to have the right painkillers, we need to have the right outpatients appointments, and we need to have a really good clinical discharge. And the ward and the trusted assessor will liaise to make sure Betty gets the best possible discharge and the care provider gets the best possible information so that she can go home, wherever her home is, go home safely, stay at home with outpatients appointments, district nurses that know she's there and might need her wound cleaned, and the GP who knows exactly what her medication is. That's what we call a brilliant discharge, and the trusted assessors liaise between all the parties to make sure everybody works together. They'll do the same if a care provider says, I'm not having her back. They'll say, actually, she's medically fit, that is her home, it's time for her to come back. And they will make sure that everything's in place before that person goes home. And that is a proper discharge. When you don't have a trusted assessor involved, or you have a ward that wants to just push somebody out because they need that bed, that person leaves with no medical information, possibly no medication, no equipment, probably in pain. They get back to where they live, which could be any type of accommodation, and within 24 hours, they're straight back in
Back
their
again.
house. And they very often die because they're not in a position where they understand what's going on. They might have an infection. And we have to look after people better. And it's not just the elderly, it's learning disabilities, mental health challenges, you name it.
Yeah, more should be said around that, because the discharge summary alone, understanding it, it's a nightmare. And sometimes people come back without one. So having the trusted assessor means that it's a bit like having this is how I understood it. It's more like having the end-to-end process when it comes to discharging, ensuring that when you come back, that vicious cycle that you previously spoke about, it breaks it. So yeah, it seems like that's actually a solution to that.
It's a brilliant solution, and I'm not in any way battering the NHS, and it's really important that I say that. And also I'm so lucky because both our local authorities and our hospitals work so well because they understand what the providers need. And in turn, it's created trust, which is why they're called the trusted assessors. And we were never able to have weekend discharges. And there were all these battles with each other. And, somebody might say, and this is a really silly example, but okay, so we've got Obi. She is now playing the triangle, the trombone and the saxophone. And sometimes we've seen her on the wall playing the bongos. Obi gets home and Obi can't do any of those things, now needs 3-to-1 input, is screaming in pain, has got a raging infection, still got a cannula in their hand. And that's not a dig at the NHS, it's because they're overwhelmed as well. We need to encourage the care sector to have their flu jabs. Nobody needs to have a COVID jab necessarily unless they're really vulnerable or they've got comorbidities. And basically what that means is you've got a variety of illnesses that will impact upon each other.
Yeah.
If you get COVID, it's going to really affect you. But I really think this year the message is, and we do hear the same message for you. So I'm just going to kind of slightly reiterate here, Obi, that one of the things I think that we do need to think about in the care sector is to have our flu jabs. I think it is quite important because it keeps us safe.
The carers, the carers, management, everybody. When you say the care sector, you're referring to the carers and who are you referring to when you say the care sector?
I'm talking about everybody who's delivering care, whether you're a nurse, a consultant, an unpaid carer, because then we keep the people safe that we're caring for. But also the majority of our vulnerable people are getting their flu jabs, which is really good. The coordination isn't brilliant across the country, but it is happening. And then with the COVID jab, some individuals who are extremely vulnerable, that should they get COVID, that would then impact on some of their comorbidities, which is the other bits that impact upon their life. But we're not offering the COVID jab to other vulnerable people, and that's a conversation I've had today with some colleagues in the NHS about individuals with a learning disability whose immune systems are low. So we need to think about these things and how do we protect people. And if we can do that, then those people won't necessarily need an NHS bed.
when you said everyone in the care sector needs to have the flu jab, I thought of business continuity within your organization. How do you track who has comorbidities? How do you track who's priority? How do you track who has had the flu jab, who hasn't? I know you said you need to start planning for winter pressures as early as June, but in terms of the process of planning, where does your business continuity fit in that process?
So, I mean, the first thing I say is I don't think, I'm not saying everyone has to have the flu jab. I just think it's helpful. But I think with your business continuity, when you're looking at your winter business continuity, you look at all sorts of things. And this is something else the public might not think about. What do we do if there's ice everywhere and the staff can't get in? What do we do if we can't get the heating on? But that is the sort of thing you will know, and your GP will know who are the individuals within your caring area that you're looking after. So the GPs will know, the district nurses will know who are the most vulnerable, because it'll be on their NHS records. But actually, we know as well, as care providers, we know who are the people that we need to protect the most. And there are also people that we might choose not to do that for, because, there may be a reaction, or it may just cause them so much unhappiness to have a jab. But in terms of winter planning and contingency planning, we all start planning way ahead. And that's why I'm really frustrated that we're now in November and some of the discussions are only just beginning, which we should have had months ago. How do
What do you think should have been done differently? Who should be starting the conversation? Where should the communication channel be the most intense? Is it through care associations? Is it through LinkedIn? Is it through social media? Is it through the TV? So who should start the conversation?
Well, I mean, surely we've got the crisis management teams and the disaster management teams within the government. So you'd think they'd probably know that there's likely to be a flu problem, because don't they work with epidemiologists and all the different people and the people who can predict what's coming our way? Just like we knew that COVID was coming our way. So if everybody's telling us that flu is going to be really big this year, well, we must have known that for a while. So why didn't we start working this out sooner? Why are people just getting random texts from their GP saying, do you want a flu jab? Why are we not having more access to it? Why, when district nurses turn up sometimes to care homes, do they not have enough flu jabs? Because the count wasn't done properly. And again, it's really important I say so. I'm not bashing the NHS.
Yeah.
So where the conversation needs to start, well, it needs to come top down, doesn't it? Because that's what needs to happen, because the public and people who are vulnerable don't know all of this. So they're the people that need to be supported. And surely the people we're paying our taxes to need to look after us. So I would say it's fairly obvious, but I would also say there's a massive lack of funds. And so if the money isn't there, can you access the drugs that you need to give? If the NHS is overwhelmed, we can't create beds and magic them out of thin air. We're in big trouble. We are in big trouble right now. And the care sector is there to prop up all of those other services.
The fourth emergency sector.
It sounds silly, but at the end of the day, let me give an example. We had, and again, this isn't going to be very well known about, there was an individual company that provided all the equipment that was needed for individuals leaving hospital. So walking sticks, walking frames, perching stools, that kind of thing. They were bankrupt effectively. They were no longer available. Now, the hospitals were in a situation where people couldn't be discharged because there was no equipment. We put out a call to our care providers across Dorset and we said, bring the equipment that you've got. We need to get people out of hospital. What have you got? And those care providers rocked up to the hospitals and the physio teams met them, greeted them, said thank you, and they shared their equipment. That's just an example of where we will jump in and support everybody that needs us. But what gets missed is we're not funded enough. We've now had international recruitment stops, so we can't necessarily get the staff. So now we're not as able to be the fourth emergency service. We don't have as much behind us to be able to say, we can help. So if we go back to trusted assessors, that's where it's a really important role. But I cannot emphasise enough, they need to be independent. They can't work for a hospital and they need to support the providers.
So right now, trusted assessors work with the hospitals.
There are trust assessor teams that haven't worked because they've been kind of sucked into the hospital. So they've got involved in pushing providers to take discharges. Whereas my team, because the local authorities support them and so the hospitals, work to make the centre of that the person who they are supporting, the patient. So they are all working around that person. And that's the focus. So they know that to get them home, they have to tick box A, B, and C. And that might involve therapy, might involve pharmacy, it might involve surgery, and it might involve just something to build them up again before they go back.
So if there's a provider somewhere, they've listened to this and they think, oh my goodness, I want to engage a trusted assessor. What's the first step?
Depends if they've even got trusted assessors. There are not many trusted assessor teams around the country,
Yeah,
but
exactly.
there's various funds. There's the Better Care Fund, there's the future programs. There are all these different things where the money is about effective discharges, keeping people safe. And that is where it needs to be really well thought out. Could you use that to make discharges quick and safe without
Okay.
failure?
So is it
So
the care provider that has to apply for the fund? How does the funding
no,
happen?
no, no, no. It's got nothing to do with the care provider. The care provider is the end user. So it's the care
Yeah,
provider that requests the service. The funds have to be distributed by the local authority, and that comes down from government level. So the bottom line is it's got to be a local authority who understands that the trusted assessor service should be independent. It should
value.
benefit the care provider, but ultimately the person that benefits is the patient.
So, for example, a local authority somewhere, they don't have trusted assessors. Would you say providers should maybe raise it with the care association so they could then raise it with the local authority to get the fund to ensure that there are trusted assessors, especially when there's evidence through Dorset that it actually helps with winter pressures, it helps with better discharges, it reduces the amount of return and the vicious cycle of hospital discharge, home hospital discharge. So would you say that that's a fair way of actually getting trusted assessors into local authorities?
Yeah, I think it's a service that people fear, not providers, but when the term independent comes into it, because they worry that there'll be a battle. But actually, a really good quality team of trust assessors will be only on the side of the individual that it's all about. Now, it took us, I would say, 3 to 6 months and to win the trust of the wards, the trust of the consultants, the trust of the discharge team, the trust of the care providers. Bit of a battle, but we got there. We've now done over 5,000 discharges without
It's
any
amazing.
failed discharges. And that's
Wow.
because everybody collaborates. Yeah, there's a few arguments along the way,
Yeah.
but actually, everybody collaborates and works together because what we keep remembering is it's about that person. And if somebody leaves hospital well, they're not going to come back. If somebody leaves hospital poorly, they might die, they may deteriorate, or it's just a horrible journey for them. And somebody who's old, who's had a really good life, we need to make the rest of their life really good.
Is care commissioned differently in the winter because of how much is required to support individuals in winter? Would you say the way care is commissioned, from your experience, is different? Are there any perhaps specialist commissioning out there that could be maybe either help that providers need to know about to support the hospital, discharge to assess teams?
I think the biggest issue is where we started. Why didn't you start planning sooner? Why do we suddenly come into car crash winter period? And yes, people do what's called block bed purchases. So for anyone who doesn't understand that, a local authority or an NHS discharge crew will purchase a chunk of beds within a care home or a nursing home, which they can rotate and they can ask people to go into. They don't pay a huge amount for them, so it's not always worthwhile for a care provider. And some of the people that arrive at that care home in that bed are extremely poorly. And then the impact on the care home is that other residents lose out because somebody who they didn't think was that poorly needs 3-to-1 care, or they've arrived and they are so unwell, or they're very challenging, or they're hitting people. So we've got to look at how we commission, and we should start thinking about winter commissioning way ahead. And I know the commissioners do. They do that, and they do try that.
But
But
there's
then
no
there's this
funds.
massive bump in the road, which I would say in the last 3 weeks in my area, we're at what's called Opal 4, which means it is the critical state of trying to find beds for people. We're just under so much pressure. So I would be recommending that we've got specialist units who can take people and work with them. And everything I'm saying is so obvious, and I know people are trying to do it, but then there's an argument about how much somebody costs. So,
Yeah.
I might say,
It's
Obi,
always about funding and costs.
there's a price on your head, Obi. So you
Yeah.
are worth, I don't know, £1,200 a week. But actually, the provider knows that probably when you come out of hospital, you're going to be £2,700. And this is the bit that makes me angry. The providers are not making monumental profit, and the public think that they are. If you think you need a crew of cleaners, you need a chef, you need in some cases 3-to-1 care. So while somebody's receiving 3-to-1 care, you've got bells going, you need staff to be paid, you've got all your overheads, you've got families coming in, you need to be able to provide the heat, the light, and there's this myth that's being created that we are making monster amounts of profit. Now, firstly, providers should be able to make profit, just like the shopkeeper, Sainsbury's, everybody else. Surely you run a business to make profit.
Yeah.
But they're running on empty. They're not in a position where they can take some of these people and give them the best possible care, because other people lose out. So we need to be thinking about what we're offering, what we're paying. That's not local authorities' fault. That's not the NHS's fault. That comes from government down. So in terms of how the trust assessor team build up trust, it's got to work in every direction. So it's got to work with the care providers trusting them, which is why we don't use any nurses. And it's not because nurses aren't good at their jobs. They're brilliant. But it's not a clinical assessment. It's an assessment for a care provider. So it's how Betty goes back and what Betty needs. Not, oh, Betty's got an aortic valve that's not really working and, she needs some beta blockers. A nurse will assess somebody clinically, which is what they're trained to do. Whereas
Yeah.
an ex-registered manager or a team leader or a support worker will go in and say, okay, Obi is now 2-to-1. That home does not have enough staff to keep Obi safe. So if Obi goes back, she will probably fall and they will be in trouble and your mother may die. So we need to now find the right home. And the trust assessors will give that really frank and honest assessment. Or they'll say to the care provider, look, I think Obi's going to need 2-to-1 for 4 or 5 days. Can you manage that? And then from there, we've got OTs coming in. We've set up a physio. The care home go, do you know what? Yes, because you've been really honest with me. So now I know that I need 2-to-1. I will deliver that for a couple of days. But it's the same for the wards. The wards
It's
need to be able
about
to trust.
speaking the care language, isn't it? As opposed to sounding more clinical, but it's more care focused, and that's why you prefer to use ex-registered managers. I was just adding to what you were saying.
Yeah, no, and you're right, because, our lovely producer, Albert, for example, Albert doesn't know about the care sector. So I couldn't say to him, can you just come in and assess this guy? But he'd probably be more able to assess because he wouldn't be thinking clinically. He'd be looking at the environment and the individual. And I
Okay,
think
that's interesting.
that's the point. It's about forget clinical. We don't need to do that. We need to be able to say, in order for this care provider to cope, they will need. So I'll give you an example. We had an individual, this is a really difficult story, who was non-verbal, severe autism, and unfortunately regularly got constipation. But constipation in somebody with a learning disability or with autism is horrific. They end up in agonising pain. They can't necessarily tell you how bad it is.
Yeah.
That develops through behaviours. So this young man goes onto the ward, and the consultant doesn't quite understand the situation. He was only young. Mum and dad are there. Trusted assessor says all he needs is something called Picolax. Now, Picolax is something that literally blasts you through. Historically, it works. We can then get him out of the ward really quickly. He's frightened by the noises. He's frightened by the lights. Mum and dad are trying to keep him calm. His care is trying to keep him calm. The consultant says, it's not, let's just give it a couple of days and see if it shifts itself. One of the nurses who works with the trust assessor says, no, he needs Picolax because it will clear him, which will make him feel better, which will change his behaviour, which clears the bed. The consultant says, okay, I get it. So within 20 minutes, he'd had his Picolax. Whatever the result was when it cleared him. He became calm. He left. The bed was empty. Everybody worked together. And it's about that person's best interest and the best possible outcome we can get. And so we've all learned how to work together better for the person in the bed.
Absolutely love that story. And
Well, that's day in, day out, day in,
yeah,
day out.
yeah.
And
So
people go into hospital and die because they can't communicate, and that again is nobody's fault. But we have to get better at it as the general public, as staff in hospitals, as bus drivers. We have to get better at working with people who are different.
so from that explanation, it makes sense why trusted assessors will work with hospitals. So would trusted assessors only work with individuals that are in care? And will they see them because the story you've just told, I can assume that this individual regularly comes to the hospital, so they are known by the trusted assessor, and that's why they could say straight away, I know who this person is, this is what he needs, give it to him, and he's going to be better. So, do they only have to work with individuals in care? And now it also explains why, or again, I may be wrong, but it also explains why they would maybe want to or need to work in hospitals because
Well,
would
let me
you,
flip that on its head, Obi. Let me flip it on
okay,
its head. What if, and again, people who don't understand care won't know this, a care home or a care provider is not allowed to administer that type of medication because it's got to be administered by a professional. But if I was
uh,
having a colonoscopy at home, I can give it to myself. So there are some extremely stringent rules that make monster impacts. So wouldn't it have been easier if the care providers and the carers could go, okay, Bob is getting backed up here. He's getting constipated. His behaviour's changing. We felt his tummy. It's rock hard. Let's call a district nurse, or even better, let's administer the Picolax ourselves. He doesn't have to go into hospital. He doesn't have to suffer. He doesn't have to have his family there, a trusted session, everybody else. So this is really basic stuff. He doesn't even need to go in because those staff know him. His family know him. When he was at home, his mum and dad would have been able to do it. But when you leave your home environment, you go into a regulated environment by CQC, local authorities, quality assurance, all of those, suddenly the rules are incredible. And I understand why. But let's just say those pressures are there and it's winter. Why don't we override them? Or why don't we say, when you ring 999 and they say, we're sending them paramedics, and he goes straight in, front door of the emergency department and straight into a bed. How about ED says, don't come in, or the paramedics say, why are we bringing this young man in? He doesn't need to go in. It's blocking a bed. He's going to get distressed. We're going to get some Picolax and bring it back. And anyone who's a paramedic would be thinking, shut up, Anna. We haven't got time for that. But we've got to find some solutions because that would
yeah.
solve that problem, wouldn't it?
I think this episode should be called Winter Pressures, How Trusted Assessors Relieve Winter Pressures. Because this is a really clear
You're a poet or
explanation.
something. The thing is, this is, I guess, part of the episode that, having had a pop at me about being 54 and needing a bloody flu jab, Jesus, actually, just be confident because these conversations, this isn't about selling anything or anyone going, oh, look at the way
Yeah.
he's thinking. It's actually about us
Our every
saying,
day.
what people need to know about this. It's such basic stuff. And, when you read,
Actually,
so
not basic stuff, Anna. It's basic because it's your everyday and because you've been in care for a very long time. Oh, you know what I mean.
rude. And that's rude again. Just rude. No, it is basic stuff. And this is why I'm going to say it's basic stuff.
Okay.
This is common sense. The
Okay.
stuff I've just said to you, well, what if, what if, what if, what if? It's common
Okay.
sense.
Okay. Okay.
So when I say it's basic, I don't mean it in a patronising manner. I just mean that the majority of us, no matter what our job is, we could resolve that. And one of the things that Albert said, who's our producer, a while back is, well, because we were talking about Gen Z and why they don't want to get into care anymore. We don't ever see anything but the bad stuff. And that's true. Why don't we look at the good stuff? And, I was reading earlier, I think I sent you this morning or yesterday morning, OB. So the
Okay.
NHS are making thousands of people redundant, about
Yeah.
18,000 administration and managerial jobs. So regionally, that's going to reduce the headcount by 50%. It is massively overstaffed in so many ways. And I'm going to give you an example. My youngest needs to go to hospital in Swansea. That's where he is at university. He'll kill me for saying this. But do you know what? It was managed, this hospital, by volunteers. Best thing I've ever seen. Everyone was
Wow.
smiling. Everybody was laughing. The consultant that we saw was laughing. We went downstairs to get a blood test, and the guy managing the blood test was volunteer. He went, Jude, you're the youngest. Go to the back, sit on the naughty step. Everyone's giggling. Everything was flowing. And it was brilliant. Why aren't
Wow.
we doing more of that? And okay, that's Wales, so it's different. But it's not that complicated. There are many people who would love to do that. And it was fun. People were having fun while they were being ill.
Yeah, because I feel when you introduce money, then it becomes accountability has to kick in, KPIs. So it's run by volunteers, he said. So this is a leading with the heart, and you could be. There's no bureaucracy, there's no red tapes, there aren't. I'm sure there are regulations, but there's more freedom. And
I
when you
think,
have freedom and care, it's a really good recipe for really good care.
and you know what we need to remember as well, and I haven't said this and I should have done, we've got the voluntary sector as well. You know, they're fourth and a half, fifth emergency service. These are the voluntary people, the volunteers who go and do people's shopping, who go and keep people company, who read to them, who pick them up. You know, there's all these things that we can be doing. And yes, you're right, accountability is really hard. And we have to do something called a DBS check. So if anyone doesn't know what that is, it's a criminal background check, basically. So obviously Obi would never pass one. I do constantly. But the reality is, you know, yes, you can't keep tabs on absolutely everybody. But we can introduce more volunteers. You know, somebody walking up and down with a cup of tea or going and sitting by someone's bed. The guy that was running the blood test gang, he was bloody brilliant. I was gut laughing by the time I left. You know, he was singing to people. And yes, for some people it might be a bit distasteful. But actually, that hospital, when I got in the car, I felt really chuffed at what I'd just been through and what I'd experienced, and people smiling. You know, you don't often see people smiling because we're not all feeling very smiley. So there's all these resources that are out there. Yes, they're not easy to access, but look at the trust assessors and the model we've got. It works, and it works because they look after everybody. You know, they will dive in and help. They will clear a bed when they need to. They will support people to get the best possible outcome. That's what it's about.
I think that's a really good explanation on how trusted assessors support, because we're going into winter. So this conversation is all about what can we do, what's currently being done to relieve winter pressures, what's working, what isn't working, who within the communities could work together. Trusted assessors, you mentioned the volunteer, the chair, VCSEs. This is a really good explanation on how, by adopting some of these processes, well, it's not a process, it's an approach, it could bring good outcomes
Yeah, and
within the
there's
communities.
something else to add here. You know, one of the things that I do when I'm working with care providers is I need a flu jab. You need a flu jab. Is that
Clearly,
actually
booking my appointment.
when you've got a paramedic crew turn up, they're equally stressed. They're at breaking point themselves. They're working long hours. They're seeing really difficult things. They're having very long waiting times where they're having to wait with somebody in the emergency department. You know, actually, as a care provider, the one thing I say to them is have, you know, plastic cups available, disposable cups, have some biscuits ready. When those hard-working paramedics arrive, they're part of our team as well. Give them a cup of tea and a piece of cake and say, here's the loo. And you know what? That immediately makes everybody feel like a team. And it's something as basic as that. And you know, Obi, I go on and on about this. Kindness is all that matters. If we are kind to each other and tolerant of each other, and let's say I'm the paramedic, I've been on a 12.5 hour shift, the crew that is supposed to be taking over me are stuck with dealing with something else, I'm knackered, and I've just been sent to yet another, let's say a care home, and the night crew say, do you want a piece of cake and do you want a cup of tea? And you think, oh my God, yes, please. Those tiny, weeny things go such a long way to people feeling like, okay, we're a team. We're all under pressure. That's the basic stuff that we should be doing.
Okay, well,
I've just solved all the world problems. It's a cup of tea and a piece of cake, people. That's all you need. I have solved winter pressures with tea and cake, and it's all very basic. It isn't very basic. We are, as a country, under pressure. I think that there are certain politicians who have been extremely focused on the NHS and really missed the point that the care sector is underfunded, struggling to recruit, More and more people have massive needs now coming into care. So, you know, they're coming into care with huge amounts of, I've said it, comorbidities, which are lots of different things that impact on their health. So what's your solution to this and what do you suggest we do?
My solution to winter pressures is I do think more education around, or not just the issues they face, and exactly how the care sector can support. So, you mentioned the vicious cycle about someone in the care home who is sick, has gone in, they're left sick, basically. I'm referring more about more collaborative ways in terms of even as far as social workers, educating social workers on how they can support care providers and not just care homes. Because I feel when it comes to winter pressures, a lot of the knowledge available, readily available, is for care homes. But people forget other services, day centers, domiciliary care services, supported living. So, and all of these services collectively, in order for all of us to work together to reduce the pressures, we need more education. Absolutely, preparation is key. Education on when to update your business plan, your winter business plan, education on what should go in there.
I think that's a utopian view. It's ideal. And wouldn't we just love that? But I think it goes back to, would you, as a government, please, and actually the general public, recognise the care sector? Because you are all going to need us and you all are going to need our services. And if we crumble and if we can't continue to care for people, we're in a total breakdown. If you're lucky enough to be an extremely wealthy person and you can afford the best possible care, you can afford £5,000 a week, for example, your quid's in. You're going to get the best possible care you can ever get. If you don't have the money to pay for your own care, things are really difficult. But those people probably worked full time for the majority of their lives and contributed to national insurance and contributed into all the different areas to give us the best lives that we could possibly have. So actually, what needs to happen is, yes, the NHS needs to be supported better. There are too many people with too many jobs. That needs to change. And some really sensible funding needs to go into the care sector. And I mean what I said in the beginning. Of course, people have to make a profit. And I think one of the things I hear on the wards when I'm working with my trust assessor team is, oh, so Mrs. Miggins in bed 7 isn't in the care home today, and so they're still being paid, so they're making a profit. And I say to them, when you go on holiday, do you pay your rent? Yeah. When you go on holiday, do you pay your mortgage? Yeah. So what's the issue? Because if we close the bed, she can't go back. But while the bed's empty, they have to have the money coming in to keep everybody employed, to feed them, to pay the heating bill. So the reality is we need to educate everybody a bit more about what the sector costs. We have to do so much training. We have to to pay CQC to come and regulate us, and they don't very often turn up. We have to pay so many things to keep people safe. So actually what you just said, I totally agree with. But come on, people, just give the care sector a bit of a breather, a bit of a break, and learn about what we do to keep your family members safe. I'm going to get a little tiny violin out now and start playing it.
Well, I feel what you can do today, because everything you've said is top heavy. So it needs, if a lot of money is injected into the NHS, until it's going to take a while to get to care providers, and it's going to take a while for systems to actually improve.
Inject some money into the care sector, not just.
So Anna, if there's, but if there's, so how about things that could be done today?
Okay, so if I was closer, I might punch you, which is lucky we're not as close to each other. I hear what you're saying, but we can't keep giving money to the NHS. We have to give money to the local authorities so they can fund the care sector. The local authorities are massively underfunded. I understand what you're saying completely, by the way. I'm just being facetious. Can't even spell that. But we have to educate more people in the public domain. Don't keep sticking panorama programs on about the bad behaviour that care providers are doing. Maybe you want to go on a ward and see what some of the nurses are doing. And I'm sorry, but it's a fact. Maybe you want to see some of the things that are going on with the police force that we see. I'm not knocking any of those services, but we seem to be pummeled constantly. We're doing our best, and there are some rogue care providers. We know that.
Yeah.
But actually, if we weren't there, what the hell would happen? So that is a wrap. I haven't punched Obi. Obi hasn't punched me. We've had an interesting debate. We've had some really good input. Thank you so much for listening to us. Might be interesting, it might not be. Let us know if it isn't. And Obi's going in and out of the dark, as you can see. Thank you for listening to us. It's been an interesting discussion, actually. And you can find us on all of our social media that we've told you about many times. See you again next week.